So just a few housekeeping items. Can everyone hear me okay? Yeah, great. Before we begin, so a few center updates. It's the seed grant reminders. The applications for the spring 2026 cycle are closed and reviews are underway. The center may fund up to 2 awards, $35,000 each for 12 months starting July 1st, 2026. Also, to save the date, the fall 2026 seed grant cycle will open on Monday, August 10th, with more details at our website. Our next Dunlevie Center lectureship will be June 11, 2026. And we will feature Dr. Christy Redhorse, professor of Department of Biology at Stanford University, studying the placenta and modeling pregnancy complications in 3 dimensions. But it is my pleasure today to introduce our honored speaker and a good friend, Dr. Reddy, who is the Executive Vice Chair of the Department of Obstetrics and Gynecology and Reproductive Sciences at the Yale School of Medicine, and who will be speaking to us about stillbirth prevention. We must do better. Just have a few words of introduction to everyone. For Dr. Reddy, she is the Executive Vice Chair and Professor of OBGYN at Yale. Prior to this, she was the Virgil G. Damon Professor and Vice Chair of Research in the Department of Obstetrics and Gynecology and Profession of Population and Family Health at the Mailman School of Public Health at Columbia University. For 25 years, Dr. Reddy has provided expert clinical care for women with complicated pregnancies and is widely recognized for her groundbreaking clinical research. She was elected to the National Academy of Medicine for her leadership of paradigm-shifting studies that have fundamentally advanced understanding of stillbirth, neonatal morbidity and mortality, and labor management and its impact on maternal morbidity. Through large multi-center cohort and clinical trials, Dr. Reddy's research has led to new national standards in obstetric practice and significantly improved outcomes for pregnant individuals and their children. During her tenure at the NIH and the NICHD Pregnancy and Perinatology branch, she served as the project scientist for multi-site collaborative studies in obstetrics, including the Stillbirth Collaborative Research Network, which is a landmark population-based study on the causes and risk factors for stillbirth in the United States. She has authored 13 textbook chapters and over 400 peer-reviewed articles, including more than 100 focused on stillbirth, with many published in high-impact journals such as the New England Journal of Medicine and JAMA. Dr. Reddy served as co-chair for the NICHD Stillbirth Working Group and has developed national obstetric guidelines as a member of the American College of Obstetricians and Gynecologists, a Committee on Practice Bulletins, and Clinical Document Review Panel. We are truly honored to have her speak with us today, and please join me in welcoming Dr. Reddy.
Well,
Lori.
Thank you for this kind introduction. I'm honored to be invited to talk to the Research Center about an area that I've been working on for almost 25 years. And I'm a big fan of Stanford and your research, a huge fan. So it's really just an honor to be here. Okay, so I'm going to give a high-level talk on stillbirth and just really talk about the progress we've made and where we need to go. Do you see a single slide? Like, can you just tell me if the slides are projecting okay?
Not yet.
No? Okay, so let me reshare. Okay, so share here. Okay. From beginning.
No, we see them.
Perfect. Okay, it's perfect? Wow.
Mhm.
Okay. I've only been doing this for years. So wonderful. So again, I'm just really thrilled to be talking about this. I want to start here. Stillbirth has been around since the ancient times. 2000 BC, there are ancient texts mentioning how babies are born still, not crying. And this is a picture of a Jizo statue. And when I went to Japan 20 years ago, when I started, getting into the stillbirth research, I came across these statues. And this is representative of Jizo Bodhisattva, who's a revered figure. And starting in the 17th century, parents in Japan had these statues commissioned to honor their babies who died in utero or soon after death. They would put these hats or bibs on them, flowers, toys, present them with water. Really, they prayed for the Jizo's peace and a peace of spirit. So it became a symbol of grieving, a bridge between parents and their lost child, and a protector of children who died before birth. And this, was a really important way to help families grieve for the loss and commemorate and honor their child. So, our goal is to prevent this devastating outcome for pregnancies. So, in this talk, I'll talk about the progress we've made reducing stillbirth rates nationally and globally, discussing the risk factors and causes of stillbirth, and evaluation of stillbirth to determine causes. Then I'll talk about the gaps. Still, there are too many stillbirths that are unexplained, the management of pregnancy after stillbirth, and then effective interventions to prevent stillbirth. 2 million stillbirths occur around the world, one every 17 seconds. 98% are in lower income countries. Two-thirds happen in South Asia and sub-Saharan Africa. In the last 20 years, the rate has been reduced by 35%. The total number has been reduced by 32%. There's an annual rate of reduction of 2.3%, but there's variation by countries in the rates of stillbirth reduction. 144 countries had a decrease, 81 countries did not. In terms of the US, our rate, this is from 2024, is 5.4 per 1,000 stillbirths. So this is 20,000 stillbirths per year, 1 in 180 pregnancies. California has a lower rate of 4.76 per 1,000. But this overall US rate is among the highest for high income countries. Japan and European countries have stillbirth rates on the order of 2 to 3%, so half. And this graph just shows it's old, but it shows that the US was at the bottom in terms of reduction in stillbirth rates per year compared to other high income countries. And so this shows US stillbirths, and it's just to show that there was a steep decline. Do you see my pointer? Okay, decline from 7.5 per 1,000 to 6 per 1,000, and then a more gradual decline. And it really has been pretty stable for the past decade. And by stillbirth, we mean fetal death 20 weeks or greater per 1,000 births. There's great racial disparity in stillbirths. You can see that Black and Pacific Islander, Native Hawaiian birthing people have double the rate compared to white and Hispanic people. Also, American Indian and Alaskan Natives women have a higher rate. So 20 years ago, there was a call to action from a stillbirth parent to NIH, and I happened to join NIH, so luck has a lot to do with how I got involved, saying, why do we not know anything? She had a stillbirth, and so NICHD had a meeting to identify the gaps, and this resulted in the NIH initiative on stillbirth. And that's where I joined. Here I am, and this is a stillbirth collaborative research network mentioned. This was a population-based study. It had 5 medical centers, but 59 affiliated hospitals covering 5 geographic county areas. So whole counties were covered. And so every woman who had a stillbirth who resided in the county in a representative live birth was recruited for this study. They were invited to participate. So this was a case control study. So we got comprehensive information about all stillbirth cases and live birth controls. This included maternal interview, chart abstraction, perinatal autopsy, placental pathology, maternal blood testing, cord blood samples. This resulted in 663 stillbirths and 1,932 live births. And by comparing stillbirths to live births, we were able to come up with many risk factors that were associated with stillbirth. But even if you took all these risk factors together, it was still very hard to predict who would have a stillbirth versus a live birth. Next, we look in this slide at causes of stillbirth and screen. And what we see is obstetric causes due to obstetric conditions caused 29% of stillbirth. And these were conditions which happened in the periviable period, like preterm premature rupture of membranes at 22 weeks. You would not have done a C-section at that time, and so that would result in a stillbirth. Placental abnormalities were a significant cause of stillbirths, 24%. And this placental, this is an example of placental abruption, which was a leading cause of placental abnormalities causing stillbirth. Fetal causes, genetic structural abnormalities constituted 14% of stillbirths. Infection caused 13% of stillbirths. So this was this is an example of CMV, stillborn baby. Cord complications, 10% were caused by cord complications, not just a knot in cord, but evidence of blood vessels filled with thrombus or clot. 10% of stillbirths were due to hypertensive disorders, 8% due to other medical conditions such as diabetes in this case. But despite the state-of-the-art workup with perinatal pathologists, a full 24% had no cause of death found. So we concluded that through a systematic and thorough evaluation, you identified a cause of death in most stillbirths. Placental and obstetric conditions were the most common causes, but 25% were overall unexplained. So then we became interested in explaining the unexplained cases. One of the areas we looked at was genetic causes. At the time, it was known that chromosomal abnormality caused about 6% of stillbirths, and following the pattern of trisomy 21, 18, and 13 being the most common. Karyotype was the standard of care. So that detected big deletions and duplications of chromosomes on the order of 5 to 10 megabases, but this required living cells capable of dividing. So at the time, we approached Columbia, Ron Wapner and Bryn Levy screen to form a collaboration to look at microarray, which was evolving at the time. It needed no cell culture, it worked on non-viable tissue, and it detected smaller deletions and duplications, which are known as copy number variants on the order of 50 to 100 kilobases. So in 532 stillbirths, we compared microarray with karyotype. We found that microarray had a higher success rate for yielding a result, 88 versus 70%, finding a genetic cause for the stillbirth, 8.3 versus 5.8%. And among stillbirths with birth defects, even more genetic causes were identified, 30% versus 19%. So we concluded that microarray should be considered in cases of karyotype failure or major anomalies, and that it was useful as a first-line screen for genetic abnormalities in stillbirth. Then we followed this analysis by using a different emerging genetic technology, exome sequencing. Here's a picture of the chromosome. As you know, the exon is the protein coding region of the gene. Exome is sequencing all the exons in a genome, and then whole exome sequencing is what we looked at. And using the screen samples, the Columbia team collaborating with the screen team led the analysis, and they looked at 242 stillbirth cases with no known cause, with normal karyotype and microarray, and basically found that 8.5% of cases had a genetic cause by whole exome sequencing. Most cases had a multi-system developmental disorder or isolated cardiac disorder, and several genes relevant to cardiac function or SID, sudden infant death syndrome, were found. And this was very compelling because, SIDS occurs in neonatal early months, so that there could be possibly a continuum of SIDS and these genes related to cardiac function and unexplained stillbirths that tend to happen in term gestation. So basically, through examination of the screened cases, we tripled the detection of genetic causes of stillbirth. So about 18% of stillbirths have a known genetic cause. And why is this important? Because it's essential to understand why it happened to be able to counsel about the risk of recurrence in the next pregnancy and management, and also for parents to understand, even if it was not a genetic cause, knowing that information is very valuable for parents. So in terms of the stillbirth uh, evaluation, research findings only have an impact if they get implemented in clinical practice. So this was published in 2020. The ACOG SMFM used the findings of screen to change the evaluation of stillbirths. Based on the yield of the test, the key components of the evaluation for all patients includes getting a clinical history, fetal autopsy, placental evaluation, fetal karyotype, and microarray. If microarray is preferable if cost permits, fetal maternal hemorrhage, lupus anticoagulant screening, anticardiolipin beta-2 glycoprotein antibodies, and syphilis. We found these tests and screen to be of high enough yield. Testing for specific infections like parvovirus serology, for example, which was being done at this time, was extremely low yield. So based on autopsy and placental findings, doing testing for maternal serum and fetal tissues for specific infections should be guided by the autopsy placental findings. Additional genetic testing also based on the autopsy and placental findings, indirect Coombs, glucose screening if the baby is large for gestational age, and toxicology screening. What was not useful was placental cultures, routine torch titers, nuclear antibody testing, and testing for a large number of thrombophilias. At the time, we were drawing tubes and tubes of blood, and it just was very low yield. And then bile acids, glycohemoglobin, and thyroid function if there are no features of disease. That basically, when there's features of disease, then these conditions like cholestasis of pregnancy can be associated with stillbirth. But if there's no features, clinical features, it's not like having an elevated bile acid is going to be associated with stillbirth. We found that there was no usefulness for testing stillbirths for those conditions subclinically. Okay, so pregnancy after stillbirth. This is very difficult for couples. There's often sense of anxiety, failure, personal guilt. There's a lack of closure. The cause of stillbirth remains unknown. Patients were never counseled optimally postpartum. It's challenging for us as clinicians to optimally counsel, evaluate, and manage. And historically, there was very little known about pregnancy after experiencing stillbirth. We do know that the overall absolute rates are 1 to 8%, so increased in the subsequent pregnancy, that there's a fivefold increase in stillbirth compared to those who had a prior live birth. We do know the risks for a few conditions such as antiphospholipid syndrome, some genetic conditions. We know there's a higher risk of stillbirth if the prior stillbirth occurred at an earlier gestational age, if there were current pregnancy losses, non-Hispanic Black women, and if there was a history of fetal growth restriction. We also know that preeclampsia, abruption, and preterm birth are all increased in the subsequent pregnancy after stillbirth. So I'm going to switch to clinical care and talk about actually pregnancy after loss or rainbow clinics. And this was a model that was founded for specialized care for families who've lost a baby. And it's patterned on a UK model founded by Dr. Alex Hazel. And so in-depth investigation into the prior pregnancy loss is done. In these clinics, patient-centered care with a development of plan in partnership with the provider, providing emotional support, and also doing research. And so in the UK, the Rainbow Clinic has had positive outcomes. They've shown a significantly decreased recurrence rate of stillbirth, so 0.3% versus the expected 2.5%. The training of staff and healthcare providers as part of this clinic, it actually goes beyond the Rainbow Clinic. It seems to improve care throughout their system. So there is an increased return on investment. And it's important because it decreased anxiety and depression in parents who are part of these Rainbow Clinics. So translates to improved health. But the main thing about rainbow clinics is it provides families suffering a stillbirth with continuity of care. And importantly, there's training before becoming a rainbow clinic. So the continuity of care, being able to provide mental health support during the pregnancy. And this is so important because I've heard over and over again from parents in a subsequent pregnancy, the first thing they expect to hear is bad news. And so they're holding their breath until, we are able to document fetal heart motion. So really providing the support and, the frequent ultrasound for reassurance. Doing the viability scan early, the standard ultrasounds, explicit fetal movement guidance. And ACOG has, recommendations for serial growth ultrasounds and starting, non-stress testing at 32 weeks. The specialized training, so everybody gets trained on how to interact with these parents. So not just doctors, nurses, but the medical assistants, sonographers, mental health providers, even the front desk and reception are trained. Parents have over and over said it's just so nice to be able to walk in, make an appointment, a follow-up appointment, not be asked, what are you here for? Or assuming, oh, what's your baby's name? Asking about the baby as if not acknowledging that they had a stillborn baby. So very important for parents. So what are the best practices for providers? I think, just in general, building rapport to foster trust, explaining everything in detail and being prepared for questions. And sometimes these parents ask repeated questions and they talk about grief brain, where like, even though, you're answering their question, they're not registering it because they're kind of reliving the experience of the past pregnancy. Asking open-ended questions, reading between the lines to getting at underlying concerns, and really designing a personalized care plan together because perceived specialist care, validation, teamwork bolster confidence. And then I think for all of us who see patients, when in doubt, just ask. Everyone grieves and copes differently. So just asking questions. Do you want to talk about your baby who died and knowing the baby's name? What are you worried about? What questions do you have? What are you finding triggering? This must be hard. What can I do to help? So in terms of this U.S. Pregnancy After Loss Network has started, and I'm part of it. And so it's a collaboration of the first three U.S. PALS clinics, so Mount Sinai, Columbia, and University of Utah, along with the Natalie Foundation, the Iris Fund, and collaboration with the International Rainbow Clinic Network. Yale and UCSF just recently became sites. And really the aim is to improve care in pregnancy after loss, patient experience, mental health outcomes, birth outcomes, and the goal is to replicate this model across the US. So I said this is an overview talk, so I'm going to switch again and talk about potential interventions to prevent stillbirth. So how preventable is stillbirth? In the screen study, 22% of stillbirths were potentially preventable. And the leading cause was placental problems at 12.7%. Maternal medical conditions followed 6% of stillbirths were potentially preventable, and then hypertensive disorders. So can aspirin prevent stillbirth? Aspirin has anti-inflammatory effects. It improves placentation. It has few side effects. It's safe during pregnancy. It's widely available. It's inexpensive. The benefits of aspirin are well established for preventing preeclampsia, and this systematic review of 28,000 women, not only was aspirin associated with a 15% reduction of preeclampsia, preterm birth, and small for gestational age, but overall 15% reduction of stillbirth and neonatal death. And so the question is, let's see, why are the slides not advancing? Oh, should we offer all women aspirin to prevent stillbirth as well as preeclampsia, of course? What about decreased fetal movement? Often women report having decreased fetal movement prior to stillbirth. So could earlier detection of decreased fetal movement be a way to prevent stillbirth? So this is results from the AFFIRM trial, which was conducted in hospitals in the UK and Ireland. And they studied an intervention education package for all clinical staff about the importance of recent changes in the frequency of fetal movements. So increasing patients' awareness for reporting decreased fetal movement, and then also how to manage decreased fetal movement. So over 400,000 pregnancies were studied. Unfortunately, there was no difference in the stillbirth rate pre and post intervention. And in fact, it increased rates of induction of labor, cesarean delivery, prolonged NICU admission. So clearly more research is needed on how best to quantify fetal movement. What about focusing on risk factors? Our research team showed a long time ago, it's been 20 years, that maternal age by itself was an independent risk factor for stillbirth. As you see, the weeks of pregnancy along the x-axis, and you can see this top line is for women who are 40 years of age or greater, that there's an increased stillbirth risk all along, and it really increases at 37 weeks. And you can see here, this is body mass index, and you can see as body mass index increases, the relative risk of stillbirth increases. So with a body mass index of 40, there's a twofold increase risk of stillbirth compared to a normal BMI. This is a non-stress test. So basically, ACOG recommends enhanced fetal testing based on elevated BMI, advanced maternal age, if there are other factors. But this would involve testing potentially 20 to 30% of women. And we also don't have studies that these additional tests have the intended impact on stillbirth. What about sleep position? The Sydney stillbirth study was a case control study of women who had a stillbirth, and they were asked what position did they wake up when they had the stillbirth, and they compared the answer to women who had a live birth. And what they found was that women with stillbirths were more likely to say they were sleeping on their back compared to women who had a live birth, suggesting a link between back sleeping and stillbirth. However, this got lots of press. And, we had patients asking about whether or not, are they in danger because they found themselves sleeping on their back. But the problem is confounding, of course, because when you had a stillbirth, you may not feel the fetal movement, and then you may end up not waking up and finding yourself on the back. So it's very confounding. So NICHD funded the Newmont to Be study, and there was a prospective study where 8,700 women underwent a sleep questionnaire. So this started in the first trimester, and 3,100 women actually had objective measurement of their sleep position. They wore this monitor on the right overnight. So both the subjective and the objective monitors found that monitoring found that back or right lateral sleep position was not associated with stillbirth or adverse pregnancy outcomes. So that was helpful information and different results when studied prospectively. What about detecting fetal growth restriction, which is really defined as the fetus not reaching its inherent growth potential and is based on parental size? We know that fetal growth restriction increases the stillbirth risk sixfold, and it's found as a factor in 25 to 50% of stillbirths. And the UK POP study was of first-time pregnancies. And what they did was, Gordon Smith was a PI. They did research ultrasounds at 28 and 36 weeks to measure growth. And so what they found was that there was increased detection of fetal growth restriction in the research arm of 57%, versus 21% standard of care. So just, doing fundal height and, getting an ultrasound based on a discrepancy in the fundal height. So there was a threefold increase in detecting fetal growth restriction. However, there was no improvement in neonatal outcomes. So just ignore the dots in this graph and look at this, these bars, which show that as pregnancy advances, the risk of stillbirth increases. So could induction reduce the risk of stillbirth? So this is a study that all know well. Stanford was the site for the MFMU for this important trial, the ARRIVE trial, looking at elective induction of labor in first-time pregnancies at 39 weeks to see if it improved perinatal outcome compared to letting women continue expectant management, meaning waiting for them to be delivered for their reasons. So the primary outcome was perinatal composite of stillbirth or neonatal death or severe neonatal complications. At that time, we were concerned about induction of labor. Increasing the use of induction of labor would actually increase the C-section rate. And so we would only do inductions if there was a medical or obstetrical reason. And we found that there was no significant change in the primary outcome. It was a 20% reduction, but since the confidence interval reached 1, we said that there was no significant difference. But we did find benefits of induction. There was less need for neonatal respiratory support. There were actually fewer C-sections. There was reduced hypertensive disorders of pregnancy. There were lower pain scores in labor, greater perceived control during the childbirth process. So really every arm favored the induction arm. So what is the best time for delivery then? So looking at induction to lower stillbirth risk, there's a Cochrane systematic review. They looked at 34 trials with 21,000 low-risk pregnancies. They looked at induction of labor versus expectant management greater than 37 weeks of gestation. And they found that induction reduced the stillbirth risk by 70%, relative risk by 70%, and cesarean delivery risk by 10%. So induction was beneficial for those outcomes. So this is a study where they did modeling to assess the impact. Let's say we induced everyone, this is using US vital statistics. So if you induced all low-risk women at 39 weeks, so really trying to model how the effect of doing the ARRIVE trial for everyone. And they made assumptions that 50% of stillbirths would occur in the 39th week, and those 50% would be preventative induction was performed. So that's a conservative estimate. And what they found was that inducing women at 39 weeks would prevent 883 stillbirths per year, so a large number, but you would have to induce 1,675 women to prevent one stillbirth. So very high rate to prevent one stillbirth. And then lastly, getting at the racial and ethnic disparities of stillbirth risk in the US. This is research we did 15 years ago showing that the risk for Black women, which is in the blue, is increased all throughout gestation, and particularly at early gestation and towards the end of pregnancy. And so to make a significant impact on stillbirth in the US, we have to address this racial disparity, because Black women have twice the risk of stillbirth compared to white women, and they account for 25% of all stillbirths in the US. So I'm going to end the final part of my talk to talk about current and planned research and also advocacy. Right now, the genetics research continues. So looking at whole genome sequencing, there are 3 large NIH grants that look at this. So the idea is using large pregnancy loss cohorts, using whole genome sequencing to discover genes and pathogenic variants associated with pregnancy loss. Stanford is the site of a major grant. PI is Dr. Ruth Lathy and colleagues at Yale. We have a grant also looking at whole genome sequencing and recurrent miscarriage led by Dr. Yanghui Jiang. Stillbirth, there is a grant led by Dr. Talkowski, involves Columbia, the Broad Institute, and Brigham and Women's Hospital. And in all these grants, trios are being sequenced. So not just pregnancy loss tissue, but both parents. And really the goal of these grants is to get at the human intolerome, so that genes and chromosomes regions that are necessary for human fetal development. So these grants will the results will help define that. And as Yasser mentioned, I was fortunate to be co-chair of the NICHD Stillbirth Working Group. In 2023, it was a congressionally mandated task force to examine stillbirth in the U.S., and we focused on current barriers to collecting data in the U.S., communities at higher risk for stillbirth, the psychological impact and treatment for mothers following stillbirth, and then review the known risk factors for stillbirth, and issued this report. Then we had a series of follow-up meetings and a follow-up report on how to implement recommendations and presented a concrete action plan for reducing stillbirths in the US, and this was issued in 2024. I was fortunate enough to be invited to speak on the provider perspective on stillbirth as part of a panel celebrating the signing of the Maternal Child Health Stillbirth Prevention Act in 2024. In September of 2025, the NIH funded the Stillbirth Research Consortium that I was very fortunate to be part of, selected for, along with my colleague at Columbia, Dr. Zhao Zhu. And so this is composed of 4 research centers and the Data Coring Center funded by NICHD. And the goal is to engage people with lived experience to help guide the research to advance knowledge about stillbirth. And so the goal is to understand the mechanisms leading to stillbirth, develop better tools for prediction and prevention, and test interventions through clinical trials and implementation strategies. So it's just got started. There are so many people that I need to acknowledge who've helped me, present the work along the way in support of my career at Columbia and NICHD, screen collaborators, parents who've been helpful in giving me their feedback on the research. So I just want to thank all the mothers and fathers and families who suffered from stillbirth and have participated in our research and have had the courage to share their stories and experiences, and really through participating in research and their advocacy to help prevent stillbirth. And I just, lastly want to thank my family for their support. We're very lucky that we have 2 sons. Our older son, Victor, and his wife, Anisha, just had a baby. So we have our first granddaughter, Leela, and she was brought safely into this world 7 months ago. So thank you.
Thank you so much. Absolutely fantastic. And I think you're seeing everyone clapping and sending you commendations across the screen, Uma. And congratulations on your grandchild.
Yes, thank
Lovely.
you. Thank you.
Let me open it up to questions in the time that we have remaining. And you are perfect timing, by the way. So thank you. Anyone have a question that they would like to ask? I can start off. If there was, you look at all the etiologies that feed into stillbirth, and you gave some percentages around causes, but if there was something on a broad societal public health level you could do that you feel would have the greatest impact on stillbirth, do you have any thoughts on that?
I have two areas, and I think came through the talk. Placental abnormalities. That's where the money is. It is the cause of stillbirth, and so focusing on that and how we can predict those cases for closer surveillance, and also imaging and biomarkers, and really, because we can take all the risk factors, but we are not going to be able to say who has a stillbirth to be able to prevent it. So I think that's one area, focusing on placental abnormalities and function. The second area, as I mentioned, is the racial disparity, because we have to get at why that's happening. And so, studies looking at, doing a deep dive into understanding what the factors were contributing there are crucial. And hopefully the Stillbirth Research Consortium, that's one of their goals, is to also address that racial disparity.
Great. Thank you. And
it's just such a coincidence, right within my field of vision are 2 people who just popped up. So Yoel Sadowski and Elliot Main. They just
and Elliot has his hand raised.
So building on your last point, Uma, there are groups that have twice the rate of stillbirth or more, Black mothers, older mothers. In all the epi studies that have been done in the past, is there any difference in the underlying causes in those groups? Is it more genetic abnormalities? Is it more hypertensive abnormalities or hypertensive conditions? What's driving, that sometimes can be helpful in better understanding.
Yeah, so clearly there is an increased risk of morbidities such as diabetes, preeclampsia, certain risk factors such as high BMI. So driving some of the increased risk for Black patients. However, even if you take those factors into account, and also even access to care. Because low income, comes out as a risk factor consistently as well. But if you take even that into account, sociodemographic factors, there's still residual risk of, stillbirth, higher stillbirth rates for Black women. And then also other populations in the U.S., Native American and Pacific Islanders. Like Hawaii has a very high rate of stillbirth. Yes. So
it's been having been on QI committees in multiple hospitals reviewing every case of stillbirth, it's been a very frustrating frustrating process of trying to find preventive, anything that could have prevented the stillbirth in most of the cases.
Right. It's especially, it's the term stillbirths. They're the ones that seem to be, more unexplained. So, yeah. I mean,
well, you showed a graph where there was, if I'm recalling, a decline in rate of stillbirth in the United States over a course of many years. The explanation for that, especially with the rise of maternity care deserts, which presumably would be a counter to any decline in increased risk. Do you have a sense of those trajectories?
Yeah, I mean, I think, the steep decline, through 1990 is just improved care, for medical conditions, and then, improved, ultrasound and detection of fetal growth restriction and being able to, do Doppler studies to monitor blood flow and timely delivery. But we are kind of we're at a standstill now, and that's why we have to dig deeper.
Yeah. Sarah, you have a question. Your hand is up.
Yes, thank you for this wonderful talk. I'm a gastroenterologist, actually IBD focused, with a really a large population of preconception and pregnant women. And I wondered, is there any early data looking at microbiome shifts in the gynecologic or GI microbiome in these women? Are you aware of that?
I am not. Oral microbiome, there's data. So there's data that oral microbiome has been associated with stillbirth. But no, I'm not GI microbiome specifically.
Thanks.
And Dr. Bianco has her hands up. You're on mute, Catherine.
Oh, and actually, just to follow up on that question, though, just to expand, but it's a very important area. We do know, certain infections. Thank you, Deidre. We know about certain infections in the relationship of stillbirth, like viral infections, but there are a whole host of viral infections we don't know about. So doing that kind of exploratory shotgun analysis is very important. So hopefully.
Great.
We get it, more infectious causes.
And Catherine managed to unmute. Congratulations.
I know. Thanks to Nikki here.
It's a little complicated in these rooms.
It's great to see you again, Uma. A fantastic talk. I really enjoyed. I was thinking about it like more with the AI and the different things that we can think about it and all that. Had you encountered any proposal coming down the pipe or something like we perhaps can start thinking, monitoring at home? I read some stuff that there are even sensors, monitors that you can put in maternal bed and they can change the sort of like the circadian cycle and say perhaps you are at risk to have a stillbirth. I mean, if you look at them, they're esoteric things. But I was wondering, have you seen any wearables or any AI integration into this?
Yeah, I mean, that's definitely the future because there are, just, in terms of just using AI, like so placental imaging, so you can measure the placenta, you can measure placental volumes, but you can use, computer, aided interpretation of those images. So have AI analyze those images. So that's an area of great interest. In terms of wearables, yes, I mean, there's, a group that presented at SMFM. They have, an app that is correlated with fetal movement. You hold your iPhone to your abdomen, and it accurately has been picks up fetal movement, and they've already shown the correlation with ultrasound. So yeah, that is, an area ripe for research, actually.
Yeah, I think they just published in the gray or the green this month.
Right, they did. Yeah, because it's clear just asking women to count, the false positive rate is high, so then you get, unintended consequences.
Right. Kimberly, you're on mute, but you have the last question.
Hi, thank you. So my name is Kimberly. I'm actually an obstetrics anesthesia fellow. I've been rotating with MFM, so Dr. El Said has seen me this week. But I want to say thank you because my research focus is interested from the anesthesiology perspective, like managing postpartum pain for these patients and intra-op pain, as well as, their outcomes from a social and standpoint. And so I think it's always great when you present this because I can see from an obstetrical standpoint, since I'm not an obstetrician, I'm an anesthesiologist. And so it gives me a lot of good info on what you guys look on and work and how, these patients present to you. Because I only see them for a brief amount of time when, we're trying to follow them intra-op or, on the floor. So thank you so much for your talk. This was amazing.
Well, I'm just, you're a star. I mean, it's wonderful that you are attending this as an OB anesthesiologist. And, you have an important role. Actually, that Rainbow Clinic training convinced anesthesiologists to also participate because, right, I mean, these patients, the most important thing is continuity of care. And so, yeah, after the delivery. So it's wonderful. Thank you for attending.
Thank you.
Uma, thank you so much. Just wonderful talk, a great overview, and I think you can tell by the questions a great deal of interest from everyone. We are deeply appreciative of your time, your expertise, and everything you've done for our discipline and continue to do. So thank you.
Thank you. It's been a great honor and nice to meet you all.
Thanks. See you soon.
Bye.
Bye-bye now.